Director of Cardiovascular Research Sciences at the hospital of very sick people in San Paul's Hospital in Barcelona. And it's a great pleasure to introduce her. What a mess. Sorry about that. Yeah.
Thank you very much for the introduction. Well, at this time of the morning, we all agree that we are talking of something that is rather problematic. Most of what I have to say has already been discussed, and I'll try to really set my view of this complex situation. Okay, we know that cardiovascular risk factors are causing cardiovascular disease. And the association of LDL with cardiovascular disease is clear and there is no controversy around it. We have all type of information, as was presented before, that associates LDL with disease. LDL is a particle that is a little bit simpler than HDL, and therefore the causal association was clearly established. On the contrary, HDL has been associated by epidemiology with cardiovascular disease, with atherosclerosis, but we have data that are conflicting regarding how the association is produced and how beneficial effects can be expected from HDL that epidemiology told us. HDL is a rather complex micelle, and in addition of the structural components, is able, as also was discussed, to transport different proteins and lipids that associate in many instances by electrostatic charges, and therefore is that the particle catches up other proteins that are in the circulation. But it's my point of view that against what has been circulating, that HDL is a biomarker of disease and maybe is not causally associated to atherosclerosis. It's my opinion that we have enough data to tell us that probably is associated with atherosclerosis, but rather because of the complexity of the particle, it's sometimes difficult to see it. So this is the situation we are talking today regarding cardiovascular disease and HDL. And the most simplified system tells us that HDL tries to repair what LDL has impaired. And in this easy sentence, we have a lot of functions that are associated not only with lipid deposition, but with vasculoprotective activities. So when the success of the trials using drugs that lower LDL could not really reduce event presentation or even death further than 30% of patients having benefit, the rest of the patients without benefit was considered that this residual risk was associated to an effect in HDL. And therefore, pharmacology started to look for drugs that could raise these HDL levels in plasma to be able to overcome the situation of deposits of lipids in the vasculature. However, with these new drugs, complexity started to increase because the results were not as we expected. Now, there are many data, and I removed, while I was seeing the previous presentation, some of the slides I had because to avoid redundancy. But there is also data published. Some of this data is from the 90s, so it's old data, telling us that also in patients with without LDL impairment, low HDL is associated to disease. So in this case, this was a series published by Genest showing that when HDL was lower than 35, and this is HDL measured as HDL cholesterol, so the cases had these lower levels of HDL in a significantly higher rate than the controls. And there are many more published. And also some data came from the comparison of the event rates in patients on treatment for LDL. So in this case, is a treatment with torcetrapib. This was treatment for HDL. And Barter, that was the principal investigator of this trial, that, as it was discussed before, was stopped because of side effects of torcetrapib. But the point that he could make is that the on-treatment HDL levels of HDL were able to predict cardiovascular events. And this was true for 2 levels of treatment of LDL, for a TORBA 10 and a TORBA 80. And this was also true in other studies done with the statins, where simvastatin, pravastatin, and the statins on the earlier times show that HDL cholesterol levels, on treatment HDL cholesterol levels, were associated with coronary events. And if you compare, for example, the levels of HDL in the 4S, the association with the levels of HDL cholesterol for this population that was very well treated for LDL cholesterol, the event presentation associated to the levels of HDL. And we are talking of HDL measured as cholesterol, so not the best HDL yet. And this is more recent work. It's a meta-analysis published in 2010, where they could associate that low HDL levels, even in the statin-treated patients, associated with increasing cardiovascular risk. And the increase was found in myocardial infarction, but also in other types of diseases coursing with atherosclerosis. And the statin-treated patients had a median of events of 7.1 per 1,000, and in the controls 8.3. So they had more events, but not differently if the patients were treated or not treated with the statins. So all type of results out there. Now, what do this balance of LDL and HDL cholesterol produce in the vessel wall? It's considered that LDL contributes with cholesterol to the vessel wall, and that HDL removes cholesterol. And the measurement of this reverse cholesterol transport has been attempted in different ways. Arnold was discussing in the discussion time the latest paper published by Rader's group, where he could measure reverse cholesterol transport in a cell line, an inflammatory cell line with serum from patients, and could see that there was a difference depending on the presence of coronary disease in this capacity of reverse cholesterol transport. But once we are here, I was asked to speak about what matters, HDL quality or HDL quantity. And obviously, it's our opinion that this dichotomy is probably regulating the results that we have in the literature, both clinical and experimental, because for many years we have been talking about HDL as a micelle that was measured by cholesterol, and considering that it was an entity, and we have been learning in the later years that this is not the case, and that we have a variability in what we thought it was something as steady as LDL. I'm going to start by reverse cholesterol transport and vascular protection. You saw before this slide. So now we know that this is, as we know today, the metabolism of HDL. So ApoA1, the protein-rich molecule that is synthesized, called pre-beta by some, it's modified by LCAT, is remodeled, is said nowadays, to take these different forms, HDL3, by taking cholesterol. Cholesterol is accepted by the ApoA1, and the phospholipids in this new micelle as a reservoir for the mobilized cholesterol. Cholesterol esters are formed, and LCAT complicates or remodels this particle. And this cholesterol comes from reverse cholesterol transport from peripheral cells. So initially in the 80s, when we started to be interested in this area, and this was for us a hobby, as my boss told me, this is a hobby, you have other interests. And we worked these extra hours. We were not so knowledgeable as today. We didn't know about this, but we knew that cholesterol was removed from peripheral cells by the HDL. So therefore is when we decided to run a study, experimental study. We only had the epidemiological data. And we decided to run the study using these HDL3, very high density HDL lipoproteins, as we call them at that time. And we isolate these very high density lipoproteins with a little cholesterol ester from healthy rabbits. we decided to treat the model that was most common at the time, that was the atherosclerosis rabbit model, produced by feeding a diet rich in cholesterol to rabbits. And what we obtained was these two types of results. In one set of experiments, we measured progression. So in a way, a group was the placebo group, and the other group was being given this HDL, very high density lipoprotein particle treatment. And what we saw initially was that the amount of atherosclerosis in the vessel was significantly reduced. This was Sudan 4 positive areas in the aorta. This is what we measured at the time. And what we did is to treat during 8 weeks with this preparation, 50 milligrams once a week. And why we did once a week? Because we did the pharmacokinetic of ApoE1, and we saw that during 5 days we had levels of ApoE1. Interestingly, in these rabbits, the HDL cholesterol levels did not change. And this was a big critique of the time for us to publish the paper. We are re-evaluating that. The reviewer said that if we were giving HDL cholesterol, why we didn't have higher levels of HDL in the circulation? We did not have higher levels of HDL in the circulation. We responded to the reviewers that we were injecting probably ApoE1, and that this ApoE1 was not able, by remodeling in vivo, to have high levels. So the levels were not changing, or minimally changing. Therefore, we started to speculate that what we were seeing in the vessel wall was associated to the fact that we were giving this ApoE1-rich micelle or particle. Obviously, we thought that what we were doing here is interfering with the development of the disease, and we wanted to prove that we could reverse the disease. So what we did is, in the same model, we produced the lesions, as Jill presented to you. Then we had the placebo that was kept on the same diet, and another group was treated with the same preparation, with the same type of regime. And we observed that upon the produced disease, the group that was treated with this preparation was able to have a significant reduction. To be truthful, we didn't really put too much attention to this, that we were using this type of HDL. And we went back after the failure of the drugs that produced this more fatty HDL to see, well, how is that we got such a good result? And then with my brother is the other Badimon in the paper, we really reviewed the whole thing and said, well, we were using these particles. So we follow with the study. And obviously, because we had these good results with ApoE1, we put our attention in ApoE1 Milano. As you know, I mean, you are a knowledgeable audience. ApoE1 Milano is a mutation of ApoE1 that was found in a small town near Milano. These people are really octogenaries. They live many years, and they don't have cardiovascular disease, but they have very low levels of cholesterol, HDL cholesterol. So their HDL cholesterol is around, I think it's 20 or 25 milligrams deciliter. But this mutation of the ApoE1 makes an ApoE1 very capable of removing cholesterol. So we, being interested in this area, we started to work with ApoE1 Milano when this has been available. I have to tell you that to prepare ApoE1 Milano has a lot of difficulties. Milano or no Milano, so to prepare ApoE1 has a lot of difficulties, and probably this is the reason why it has not been developed into a drug. In the pharmacodynamics and the pharmacology of the preparation of this protein is complicated, and that's why companies are selling the rights one to another, because they cannot overcome the problem of manufacturing the compound. But nevertheless, now it's in Australia. Another company is producing an ApoA1 no Milano. In this case, what we study, this is more recent work, in the same model, in the rabbit, we decided to explore other actions, and we reproduce our previous data, with, in this case, using ApoE1 Milano, isolated ApoE1. And we expanded our studies to find that really the cholesterol content in the aorta was reduced also in the liver. And the effect was associated to a reduction in the inflammatory NOS enzyme, a reduction in caspase-3. You have here the Western blots. And the cholesterol content isolated in vitro test cells was really associated with the hypothesis. So the APOE1 Milano reduced the cholesterol content of inflammatory cells. And then we went into looking for the receptors that could be implicated in the process, and we found that the hypothesis was sustained. Now, let's look at the data by Nissen that was presented by Jill. I mean, she said that there was not statistically significant differences, but we look it into a different way, because in the atheroma burden, not the one plaque, but the atheroma burden, what is measured now clinically is how much atheroma is found. There was a significant change. There was no dose effect, a dose response. That's true. I mean, it was the doses were taking. In fact, the regime was very similar to the one we use in the rabies. It was 5 weeks, 15 and 45 milligrams kilo, but the dose was chosen arbitrarily. And this was a proof of concept study, And the change was 0.14% in the placebo and minus 1.06% in the treated group. But the reversal trial using atorvastatin, that was considered a very successful trial, achieved 0.4% lesion change only. And when we think that in some instances, statins can reverse plaque progression or even induce regression. So for us, the results were not spectacular, but they were better than the results obtained in the LDL lowering trials. So we were expecting much more, but there is a problem with this production. But then there was another attempt, and the attempt was by Wasman. He published in the JACC in 2010, but the initial data, he had it before, but he had difficulties in publishing. This is the truth, and he acknowledges this. But he got a similar type of result. In this case, he used the lipidated HDL. And again, the regime of treatment was chosen arbitrarily 7 times once a week, so 7 weeks. And in this case, HDL were treated by pheresis, so, and then they were obtained and reinfused. So they were autologous, so they were disease LDL, so from disease patients. And what he got was a small result, again, looking into atheroma burden. He got a result that was associated more or less similar to the results obtained with this was by the lipidation by APOE1, what was obtained with APOE1 Milano. And that's interesting because, as you will see now from our data, when we delipidate HDL, we get something different as when we have the whole micelle, because in the lipids that are in the HDL, as you saw before, there are sphingolipids that have important actions in the whole vascular protection profile of HDL. So therefore, when you change something, you are, because we are blind, the present, we are modifying different functions associated to the different components of the HDL micelle. In any case, when we say modified HDL, we have to look very carefully how these HDL are modified. And different groups in the world now are trying to use this modified HDL, and probably we don't have a parameter to compare them. And if we had different results, probably will be because we have different HDL. Now, we go to this area of cardiovascular protection. We also saw a lot of information very well presented by Arnold. I'm going to concentrate, because I removed the others, in what we have done to answer the question that we posed ourselves when we had the rabbit data, so 20 years ago. So during the last years, we have been able to set different experiments when we had funding, because we, in addition to this, we have been working in other areas because of funding drives what we can do. But we have been able to explain some of these vascular protective effects that have been associated with HDL. So when we did the rabbit study, we did many more things in addition to the extension of cholesterol in the aorta, how much lipid was in the aorta. For example, we saw that prostacyclin release was increased 4 times in the treated animals. And this was by doing the regular thing of enzyme immunoassay of the release sites of the aortas. And this happened in the areas with atherosclerosis and without atherosclerosis. So we wanted to know why and how, and if it was a byproduct, I mean, something that was associated. So in 1997, we published this for the first time, that HDL induced prostacyclin release. This was already known. This was before it was said that APOE1 stabilized prostacyclin in the plasma, and nobody knew how, but it was described. But what we could demonstrate is that in smooth muscle cells, what happened is that HDL induced COX-2. And COX-2 is the isoenzyme of cyclooxygenase in the vessel wall that produces prostacyclin. So what we saw, as you see here, it was COX-2 associated to this increase in prostacyclin, and this was a very significant effect. So what we then tried to see is we had differences in function associated to the type of HDL. And we separate HDL2, HDL3, and compare with LDL. And as you see, it was HDL2, the HDL fraction, all of them types, let's call, or forms, were associated with COX-2 induction. And we saw a little bit more in HDL3. That was significant, but maybe this clinically has not an effect, but it was a little bit more with HDL3. Now we wanted to understand how was this mechanism being produced, and we delipidated HDL. So by delipidation of HDL, we saw that this COX induction disappeared. Therefore, by delipidation, we were losing the effect, or the positive effect of HDL on prostacyclin release. And we agree that prostacyclin is important, as COX-2 inhibitors showed us in the trials where we were trying to block COX-2 5 years ago and prevent cardiovascular disease. So in a way, we progress, and we now know that this is associated with phospholipase A2, inhibition of phospholipase A2, abolish PGI2 release that is induced by HDL and without altering COX-2 expression, meaning that we have an effect that is mediated by lipid signal transduction. Now, rofecoxib, that is a coxib, an inhibitor of COX-2, was able to inhibit the secretion of prostacyclin, but not modify COX-2. And that's very clear because rofecoxib inhibits the activity of COX-2, not the mRNA for COX-2. So we have a system by which HDL was inducing COX-2, but coxib was able to inhibit the secretion of prostacyclin. So this another point of interaction is that we found that afterwards that the statins, we have been always interested in how the statins work in the concept of a patient that is treated and has also his HDL or her HDL. So what we saw that HDL had a cooperative effect with simvastatin in this case, in this way. When we had the cells, the smooth muscle cells treated with HDL, and in the presence of increasing concentrations of simvastatin, we had a release of prostacyclin that was dependent on the statin because mevalonate and geranil was able to block this effect. And this effect was absent on prostacyclin when we didn't have HDL. So it's HDL that induced 6-keto, so the prostacyclin release, and this effect is potentiated by the presence of the statin. So when in the effect of statins, what we also were interesting is in this effect anti-apoptotic. And you know that if you use statins at a very high concentration, they can produce cell death. And the effector of cell death is active caspase-3. So in this situation with a high dose of statin, these are the nuclei of these cells, we could see that caspase-3 was activated, and when these cells were pretreated with HDL, there was no caspase activation, and this is in line with Jill presented before in her data that has proven this effect for HDL. So from all this paper, we could have a signaling pathway from HDL, and probably HDL3 higher than HDL2, that links the signaling to activate COX-2 mRNA and produce prostacyclin. So it's interesting that all this pathway and all this activity is associated to lipids. And that's why we started, and I have put this to make the story short, and you have the references, that we analyze sphingosine 1-phosphate receptors, in particular 2 and 3 is the ones we found, were involved in these COX-2-dependent effects of HDL on vascular cells. And we are now working in strategies that modulate sphingosine 1-phosphate and its receptors to improve cardiovascular protection. You already know what sphingosine does because Arnold presented it to you. And in fact, we believe that many of the effects on NO and prostacyclin are associated to these lipid-directed effects. Therefore, not everything is ApoE1. And this came to us with a certain disappointment because we were really proponents of the ApoE1 having an important role in the process. Now, the paper we did in 1980 was different arms. So one arm was treated, another not. So now we have imaging technology, and I think imaging will resolve the question you asked before. We don't have a test, but we have imaging, and if an intervention works, we'll see changes in atherosclerosis. So what we did is go to the rabbit model and try to see if from pre-treatment to post-treatment, we could see a difference in the size of the plaque. And we did, and we published this in the JACC in 2008. I mean, in this case, we were using ApoE1 Milano. So to be clear, because I think we have to be very clear now in what we use and how we use it. So it was the same treatment that we used in our initial model, but in this case, ApoE1 Milano. And we had a very significant effect because atherosclerosis regresses slowly. So in a way, it was very important for the time of treatment. Now, HDL variability. Of course, the variability comes from many different points, but I have to show you this thing that we did 10 years ago now. So we are interested in why the Mediterranean diet protects against vascular disease. And obviously, when you are doing atherosclerosis and you are doing HDL, you thought, well, let's see what happened with HDL in these different diets. And here you see clearly that the capability of the HDL in these were nuns fed for 3 months with diets enriching monounsaturated fatty acids, polyunsaturated fatty acids, N6 or N3, the capacity to release prostacyclin was different for the different diets. Therefore, diets affect, importantly, the function of this HDL. And this is interesting. This group here had sardines every day. So they had to be nuns because they really accepted what we gave them because it was heavy to have this food. It were very nice indeed. So we have different types of HDL that remodel, we saw that, and we have parameters that can help us to separate them. But as Arnold told you, I mean, we have this uncertainty, and we don't know if the diameter will help, the density will help. There are many more things that at the time they are not in this table that can be affecting. But how did we resolve our situation, and how we resolve the fact that if we use HDL from a patient, we know that this HDL, as it happens with their stem cells, are not normal. So the HDL are not normal. So in a way, what we decided is to study patient groups, and we try to use technologies associated with proteomics and lipidomics to start understanding a little bit better HDL in each situation. I'm going to show you some data only. What we try to do is always separate HDL to HDL3. This is a simple way of separation, and we have a simple model to have HDL with more cholesterol and with less cholesterol. And only with this very simple separation, you see that the components of many different proteins is quite different. So some of these proteins that are associated with HDL, and I say associated because they can be just there because they are being collected, they are transported by HDL, are very differently in HDL2 and HDL3. So when the HDL is remodeling in vivo, and the remodeling also is associated to drug treatment or to the pathological situation, the components that are being transported, being anti-inflammatory or pro-inflammatory, are different. So we have approached the study of bidimensional and then characterization of this HDL. And we really are concentrated immediately in the antioxidants, cytoprotectors, and anti-inflammatory components that are transported by HDL2 and HDL3. Interestingly, PON1, it was discussed before, we have seen that PON1 in these samples is transported in HDL3. And this is quite clear. You see it here. This is the proteomics, and this is the Western blot, the validation by Western blot. We agree with Arnold that the proteomics alone are not enough. You have to validate, and if for arrays you have PCRs, for proteomics you have Western blots. And if you have the antibodies, this can be done. So we saw, and transthyretin is a protein that is involved in the transport of retinol-binding protein and thyroid hormones. An acute phase-reacting protein is an acute phase-reacting protein, is also transported in 3 more than in 2. So we believe that many of the defensive proteins are carried in a higher amount in HDL3 than in HDL2, so in the HDL that have less cholesterol. It's like the increase in cholesterol deplete the HDL of anti or cardiovascular protector molecules. Now, we are interested in atherosclerosis, and the best model to study atherosclerosis is familial hypercholesterolemia. These patients with heterozygous familial hypercholesterolemia develop atherosclerosis in average 10 or 15 years before the normal population. And this is due to the fact that they have mutations in the LDL receptor, and the LDL metabolism is completely modified, and they have usually very high levels of LDL cholesterol in plasma. But between siblings, we are doing a study in Spain. We have 3,000 persons in this cohort study. And what we have seen is in siblings, sometimes with the same mutation and the same cholesterol levels, one have the disease at 40 and the other at 60. And so we don't have an answer to this question. And we have decided to look into their HDLs. So what we have done is to look into patients with HFH with previous cardiovascular disease, control, so the relatives that don't have the mutation, and patients without previous cardiovascular disease. And we are now developing these studies. We have analyzed 18 families, 3 persons in each case, and we are validating spots. We have already observed these ones. These are the easiest ones, the most abundant ones, and we have to go into the low abundance one, because probably there we have a lot of information. But we have some initial data, and we have ApoL. We have seen that ApoL is different in HFH patients with previous versus without cardiovascular disease, and in HFH patients and control relatives. And you have here that, there are isoforms. Sometimes in proteomics you don't have a spot, you have a series of spots that are changed, and we have been following this, and we have changes, important changes in H4 and in H2 when we compare to controls. So this is an example just to show you the variability that we are facing here. And if, as Arnold said, if we will get information or not of generating all that, I believe yes, but it was going to cost us some time, because the modifications are very important. And these are apolipoproteins. These are not the other molecules that are around that are taken by the HDL. And we are exploring ApoL and other apolipoproteins. So we believe that in the process of atherosclerosis, HDL have a role, and the resolution of this controversy of the chaos that has been produced because of the failure of these new drugs in the prevention of cardiovascular disease will be solved with proper drugs. I don't think we have to say that we will not be able ever to understand HDL because these drugs have not produced the expected results, because the drugs have a special targets. We know that they are favoring high cholesterol micelles, so micelles that carry cholesterol. Some of them, dalcetrapib versus anacetrapib, they say that, well, maybe the remodeling is changed, and Chris Packer will explain this probably. But nevertheless, there are specific isoforms or remodeled particles that are affected, and we have to wait for others. ApoA1 Milano, as far as I know, has been stopped. We'll see the ApoA1 that is coming from an Australian company now. We have to spec the data with niacin laropiprant that will come soon, and we have the CETP inhibitors. All these other interventions are further away, but many groups in the world are trying to explore these as possible new drugs for the intervention at the level of HDL. And with this I finish. This is the target of cholesterol ester transfer protein, but I don't want to interfere with the next presentation. And now, just to make you happy, I want to tell you that in a collateral study, we are studying ischemia reperfusion damage. And we have used a porcine model to study ischemic reperfusion. So these animals, we do many studies, but in one of them we study if beer had anything to do. Beer, because beer has a lot of vegetables, I mean lupulus, I know how lupulus in English, hop, parsley, and alcohol. And we tried with alcohol-free and full beer. To study ischemia reperfusion, and we did all this type of analysis, and we found that the model is that you produce ischemia by occluding the LAD, and then you reperfuse after some time of occlusion, and you have them reperfusion injury. And obviously, we're studying what HDL do here and modified HDL do in this situation. But then we did this study with beer. Because we are analyzing diet events. And when we analyze the antioxidant capacity of the HDL, you'll see that the HDL were more antioxidants in the animals that were having beer, either 1 can or 2 cans, no more. And the effect was significant versus these, the animals that didn't have beer. And these animals were hypercholesterolemic, and this was autologous HDL. So in a way, what you eat makes the function of your HDL. And this is something that has to be taken into account. And probably will be the dietary intervention should be really taking into a lot of consideration. I know they are difficult to take sometimes, the advice of changing diets, but this is an important advice because we see molecular effects of changing diets or modifying diets. And as you see, the LDL infiltration, the lipid, not LDL, the neutral lipid infiltration in the myocardium was modified significantly in the animals with the beer. So this is the scar area, and this is ischemic area and non-ischemic area, the remote myocardium. There is no lipids. There is some lipids in the hypercholesterolemic diet, and no in the beer treated, and in the scar area, there is less lipid in the animals that had, but probably this is not associated to HDL, I have to tell you. So in a way, this is an example of the complexity of the situation. HDL are modified, lipids in the heart are modified, but maybe there are no relation between the HDL effects and the lipid infiltration in the heart. And with this, I just thank you for your attention, and if you have any questions.